Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this wonderful Thursday morning. Delighted we all got up and things maybe feel a little bit more normal today. We hope that continues. Today is our 200th episode, broadcasting live with you from the Dulce Simons Family Studio, and that is a great thing to be able to say. We've been at this for 200 days. Wait a minute, is it really great? Or is that really kind of tough news that this darn guy is out there still causing all that trouble for us, Hawkeye?
I think it's too bad. It's too bad we've had to be here for 200. But I hope we feel confident in our mission and getting the message out to people to try and give them the information, get them the specialists, as we saw yesterday with Dr. Love and our allergy specialist yesterday. Dr. Lisbon has been on, getting that information out, keeping that message going. Our mission to provide the truth, no flapjacking, as you say.
No flapjacking.
And hopefully keeping you and your loved ones safe and taking those steps to keep safe.
Here's what I know, Hawkeye, with you and I. We don't have another agenda.
No.
There really is. There's no hidden agenda here. We're not running for office, are we?
No.
No. We're not voting in the Electoral College.
No.
We're just here to try and tell you the truth about what's going on around coronavirus and trying to keep you and your family safe. And we've had some great people help us do that over the last few months. And one of the folks who's helped us do that all the time has been David Lisbon. David Lisbon is one of our ER docs. He is an outstanding physician here, a good friend of mine. And we're going to turn to him and to all our team in just a moment, because David keeps reminding us about different phases of this pandemic. It'd be great to have us go back with him today. David Wild is perhaps my right-hand guy here for the whole pandemic and a good friend as well. And David's going to talk to us about where we are and where we think we're going to go. And Catherine Satterwhite is an outstanding individual who is a PhD, who is the head of our local HHS office and a former faculty member here. We lost her over to the HHS, so I know they gained, we lost, but we're delighted that she's back. This is a great group of folks, and so instead of my talking too much, I want to first ask you, Hawkeye, how are we?
Again, I think we are at a plateau right now, a high plateau as far as the number of total patients, but also number of acute infections that we're treating as well. We would certainly like to be lower. We have 75 acute patients in the hospital, with 26 of those in the ICU and 11 those on the vent. We still have 66 in that recovery phase that are still here in the hospital, with 3 of those on the vent. So that's a lot better as far as ventilator use. Hays is a little bit better. They have 22 patients with 19 active infections and 3 in that recovery period. So they are at a plateau as well. But we are both certainly a lot better off than when we had 102 or 104 active acute infections, and Hays had 40 infections, acute infections as well. Still would like it to be better, and it is all relative, and it will vacillate, and those numbers will change probably from week to week. But right now, I think we've seen a plateau, which, if you look at it one way, that's good, that it's not going up, but it's bad in the fact that we still have this many people here. And the problem is we have a lot of new admissions every day, and I think Dr. Weil can speak to that.
Yeah, so let's turn to David Wild. Doctor, how are we doing on our numbers and our stats out there?
Well, I think I agree in general with Dana. It's better than it has been and not as good as we'd like it to be. And we'll keep working through what those things mean. You know, when you add up those recovering and acute patients here in our hospital, it's 141, I think, this morning, if my numbers serve me correctly. And that's a big impact. I mean, that's a big proportion of the number of total patients in our hospital. And you know, we've spoken about that at length here, that there's an impact to the healthcare delivery system, and 141 patients that wouldn't be here otherwise is definitely a challenge for us. So, you know, with that sort of background of today, I wanted to maybe take some time and tell the story of the past 10 plus months now. And we'll use some numbers to tell that story. Most of these numbers are going to be very big numbers. And when I say big, I don't mean always big in the sense of impact, total value. I just mean they're big numbers in the sense of averages. And while we'll look at averages by month or averages over the course of time or totals, here as we work through a couple of these slides, it's always important for me to personally take a moment and remember that there are individual stories that are not being told by these big aggregate average numbers. I know we've done, gone to great lengths to make sure that you out there are hearing some of those stories, because when we say there's an average age of 57, there's always someone who's at the low end of that, maybe in their teens, and someone at the high end of that range, maybe in their 90s. And the average doesn't always tell that story either. So just a good reminder for me that there are individual patients that we've shared their stories with you over and over here that are making up these numbers. But as we look at that total number slide, this is data through Tuesday that was available yesterday to pull together. So this is just here on the Kansas City campus. These are the number of patients that needed admitted to the hospital, 1,977 through Tuesday. I would bet this morning that number is 2,000. Out of those admissions, 182 had died in the hospital. So those are not patients who transfer to hospice or go home and don't survive, or go to a long-term care facility and die there. These are just patients who have died in our hospital. And that works out to be a mortality rate for those COVID patients needing hospitalized at around 9.6% over the course of the last 10 plus months. The average age of those being admitted to the hospital is 57. And the average age of those that don't survive their hospitalization is 66. And those numbers have become very stable now. They don't change much from month to month, but I'll show you some individual month numbers and tell a story about what has happened with ages of people needing to be in the hospital and deaths as we work through here. So this first slide is literally just a look at the number of admissions by month. And if you think way back in March, we were really worried when we saw 40 or 50 patients being admitted to the hospital. And you can see how rapidly the number of admissions in a month increased as we really got into the surge that we saw starting in maybe late October or early November. But in November and December, right, 450 admissions each month, 450 in a month. That number is staggering to me, knowing that most patients for a normal admission even stay in the hospital for 5 days. And this begins to tell the story of why we were feeling so much pressure to provide care for those people who needed to be here in the hospital in November and December. That number I said is just staggering to me, and that's not the number of people that we couldn't help, that we had to say no to requesting transfer, for example, because we just didn't have a place to put them safely. The next slide looks a little bit at age. So I told you, or mentioned I would tell this story. There are two lines here. The blue line is the average age by month of those being admitted to the hospital. The red line is the average age by month of those who died in the hospital. And I very clearly can remember questions early on, and they've actually continued throughout the course of the pandemic. Questions from the public, questions from other physicians who weren't maybe seeing the same number of patients that we are. Questions that say, well, this is really only 80 and 90-year-olds that die, right? This is only a disease of the elderly. And there is no doubt that there is a disproportionate impact in the sense of survival, right? Patients dying for those that are elderly. And many of those patients aren't even dying in the hospital, they're dying somewhere else. But here you can see that early on we did have an impact of age where patients were being transferred in who were significantly older. And the average age of death, say in May, was dramatically older than the average age of the patient in the hospital. But as time has gone on, those numbers, those lines, you can see them converging. The average ages of those that are dying have settled out in the 60s. And the average age of those being hospitalized has actually continued to increase. And I think that tells a little bit of a story as those lines converge. The next slide, though, really tells the story about deaths. We get lots and lots of questions about deaths, and people are interested in the numbers of deaths. And the raw numbers definitely tell a story. We've shared, I think, very often that November and December were really records in the number of deaths. They were our most deadly months to date. And you can see that here. So I'll orient you. The blue bars are simply the same values you just saw for number of admissions per month. And the red bars are the number of deaths. And then the solid red line that bounces around is actually the mortality rate, the percentage of those admitted to the hospital that don't survive. And so you can see back in March, the mortality rate was really high, but that was due to a small number of admissions primarily, and deaths early on in the process when we didn't have treatment protocols that we have today, when we had less of an understanding about how to manage this disease and what worked and what didn't. And you can see as time has gone on that the number of admissions has increased, and then you can see proportionally that in November and December, the number of deaths were really higher than they have been at almost any point in the pandemic, save March. And that's really what we've been feeling. It's become a combination, a large number of deaths, partly due to a larger percentage of those in the hospital dying, and partly due to a larger number of admissions. And that number of admissions you can see is significant. And even as recently as a couple of weeks ago, I wasn't spending a lot of time talking about that mortality rate, the percentage, because we weren't seeing that increase. But this is really a look at the mortality rate for those that died in the month, by admission month. So there are patients that are dying today, for example, or yesterday, that were admitted in December that continue to drive that rate up as their admission sort of ends with not surviving. And so 2 weeks ago, we didn't have a lot of those deaths for those that were admitted in December that now show up. And now that mortality rate looks to be a concern as well, at least in the sense of it raising over the past few months, when a couple weeks ago we were talking primarily about volume being the impact. So that's kind of the story about what has happened. And that's a very important part of the picture, I think, of today, 200 of these updates in. Would like to take a couple of minutes, though, and talk a bit about where we're going, where we think we're going, because there's just as much concern here. So this is, again, as of Tuesday, so data that was then available Monday. But this is a national picture for tests, cases, hospitalizations, and deaths. And there's some concern here, even starting with the new test number. That we haven't rebounded yet in the sense of number of new tests per day from the holiday. You can see the Thanksgiving dip there around the Thanksgiving timeline with people not getting tested as often, and you can see the same Christmas and New Year's dip, and we've not quite rebounded. But despite that, our new cases, so despite a much lower number of tests, our new cases per day has rebounded. And that means if we were testing as often as we were before the holiday, we would be finding even more. And so spread in our community continues at what is very likely the highest rate we've ever seen. And this is, of course, a national picture. We'll break this down to regional and states here in a minute, because there are really some differences from even 2 or 3 weeks ago. The hospitalization values you can see are the highest they've ever been, and deaths have rebounded as well, almost to exactly the same level they were per day prior to the Christmas sort of holiday. And actually, if we were to look at numbers from yesterday, it was an individual day record. So you would see that it has exceeded what we were reporting per day at the national level prior to Christmas. The next slide looks just a little bit regionally. And we've shared this several times before. And there is maybe, for the Midwest at least, some good news here. In that the Midwest is no longer leading, right? There was a time going into the Thanksgiving holiday where that 919 cases per million population, the population adjusted number of new cases per day for the Midwest, was leading the nation. And that was a lot in North and South Dakota, which has improved. But you can see that even in the Midwest right now, which is the lowest per capita number, the line is increasing. The slope of that line is actually increasing pretty rapidly. And all of the regions are higher than they were, with the exception, of course, of the Midwest 2 or 3 weeks ago. And so we're beginning to see the impact of this, because while we had been getting transfer requests from Oklahoma or Texas or Nebraska or Iowa or across Missouri, this week we've gotten multiple calls from places in the South, from Alabama, from Louisiana, hours away even by air transport. And that tells, I think, the story that more and more places across our country are overwhelmed as it pertains to hospital capacity. The next slide looks at some states with cases on the left-hand side and hospitalizations on the right-hand side. Again, this is population adjusted, so per million people. You can see that Kansas really is on a population adjusted level not in a good place. And we've been concerned about this for a while, higher than Missouri or Alabama or Louisiana. And maybe only sort of being beaten, if you will, by California. And that's not a race you want to win, of course. And on the right-hand side, you can see the impact of hospitalizations. While we may be beginning to trail down just a little bit, and I think we are feeling that across the state, or have been over the last week, there are many other places that are not in that boat. So that's sort of the picture about where we think we're going. This tells it too as well at the state level, just for Kansas. This tells the story over time and where we're headed. Two things I'd orient you to here. The top part of this graph, the sort of solid darker red line, just shows the trend per day of cases per million. The lighter bars behind are the actual values per day. And of course, there's gaps because we're only reporting every other day for the most part, or Monday, Wednesday, Friday in Kansas. And so you can see that we're plateaued, as Dana mentioned, I think, at a level that's high. Maybe not exactly at our peak, but we're definitely not significantly better as far as new cases. And those will continue to feed patients into hospitals who need hospital care. The bottom line, though, or the bottom part of that graph is probably more concerning. It's the positivity rate. And you can see anytime you're in the darker red, it's more than 10%. You can actually see we're off the chart. The scale here is to above 20. And we are greater than that, actually significantly greater than that across the state. And that means that we're not testing enough and that there's disease spread throughout our community that we are really unable to characterize and isolate and prevent while we're waiting for vaccines. So all of those things point to, I think, the set of circumstances that really show that we're not out of the woods yet. And I'm hopeful that we can at least maintain this high plateau and not continue to get worse. But as we look around us, there are plenty of reasons to suspect that we could be seeing increases again as we move through the next few weeks.
All right. Thank you, sir. Yeah. Anything else today, Dr. Wild?
No, I think that sort of tells you, again, where we're at and where we're headed. And if there are specific questions, I can try to answer them.
We will circle back. Thank you. Let me thank you for that. Let me turn to David Lisbon. David,
hey.
How are you?
Good.
Doctor. All right. So early on, you brought us a graphic showing the anticipated health footprint of the pandemic. I remember this well, and I had to study it for a while because it was pretty good. I thought, what is he saying to me here? It had 4 waves: emergency response, the impact on other urgent health care needs, interruption of care for patients in chronic conditions, and then the mental anguish. And I just want to tell you, we have experienced all of these.
Yes.
Sometimes concurrently, sometimes a little separate, but we have experienced all of them, just as you forecast back. I think this is like March or April.
It was March, actually,
Yeah, it's so. What worries you most now about this? Where do you think we are? Where do you think we've been?
Yeah, I think as I look at this, probably the most brilliant thing about this graph is the person just put time and didn't actually try and measure like 2021, 2022.
Yeah, because I'd sure like it to all have ended on December 31st, but it didn't end.
It's not ending.
So in reflecting on 10 months, basically, that's how I kind of measure time or think about things of this pandemic. Yes, I had no idea that in 2021 we'd be here discussing this kind of graph for the same problem. So I'm humbled by that. But I think what's very interesting is, to me, presently, you could almost draw humps that had this graphic in it for each surge.
Well, that's true.
Because with each surge, we have to deal with the notion of whether there was going to be a repeat of the immediate mortality, and then that would be followed by to some extent by the impact of resource restriction. Very on in the pandemic, it was very severe. We adjusted a bit, but July, August saw this new surge. We had to think about, do we hunker down again and do things like postpone surgeries, be more judicious about outpatient appointments, and then that led to the third wave of the interrupted cycle of care. And then, of course, this psychic wave has definitely taken on a sinusoidal type of curve, so to speak. It's just there. It's at the baseline in a lot of ways for people. The economic impact, I continue to see folks who've actually, lost work, had housing displacement. You pile that in on top of a family member being sick, and it's just a stressful environment that the whole population is basically living in. Certainly some people more affected than others, but nobody's escaping this. So to me, the thing that's happening is this continues to be a relevant graphic, and most of these things are now running concurrently with different parts of the wave having different impacts. And some of that's even regional, like presently California is in a situation where their resource restriction is really through the roof. Beds, they've cut back on all kinds of any ancillary type of work just to handle the sharp increase in COVID cases and the concomitant morbidity associated with them.
Yeah, these are really tough times, and that bed crisis is clearly a concern. And I think, David Wild and I were talking yesterday, for a while, our bed capacity, we had some, even though our COVID patients got up even higher than they are now, because other diseases seem to be a little quieter. But today, our bed capacity is pretty limited because those other diseases are accelerating, which you typically expect in the winter. So I know we're all feeling the pinch of that.
Yeah.
So you have another graph.
I got a couple of more. So that's a graph that basically looks at the positivity rate of the COVID patient or of COVID patients through the emergency department. We've been tracking that week by week. A shout goes out to Kelly Howe, our nurse manager, for compiling these. We reached basically a high of about 10.2%. Of our patient population testing positive for COVID. Now, it should be said that we are testing a lot more now than we did then. So early on in the pandemic in March, there were maybe 127 people a week we tested. Now we're up to about 528. Wow, so we've got an overall positivity rate for this time span of about 8.4%. The next slide actually, it looks a little busy, but it actually looks at the question of, well, if you're COVID positive, do you get admitted or go home? And basically, that percentage is about 61% of our patients who are COVID positive end up getting admitted. It's sometimes not all because of COVID. It is because of concomitant and comorbidities that go along with it. Perhaps it was just COVID alone, they could go home. But that's kind of what our story is at the moment and through time.
What's the thing that drives you to admit patients? Is it a need for oxygen? What is it?
Oxygen's a big need. Vulnerability, meaning maybe a home environment that can't sustain or support the intense kind of watching they might need. Certainly, we have evidence to suggest that if you've got perhaps sarcoid, your great work with the CF patients, we would consider them at increased risk. It's been interesting. Age alone, I've been surprised. I've had some elders who were positive for COVID. Everything else was okay. These are long-lived octogenarians and nonagenarians, and they seem to do okay. And if we can line up everything, we're okay with sending them home. So we do try and individualize it on a case-by-case basis, but there's a keen awareness that age is one of our levers to think more conservatively. Certainly, diabetes and hypertension, heart failure, those are ones I'm very reticent to say, take a chance at home. I would rather that patient actually, I had one last night that I said, the balance of my experience says it's better for you to be in the hospital. If you turn for the worse a little bit, at least you're here. And that's a better circumstance than being at home in my estimation. Now, the next slide here does a job of saying, okay, as you age, what happens with your admission versus go home percentage? And this is interesting to have looked at this data for me because as I'm working in the ER day after day, month after month, I had the gestalt that, wow, once you get to be about 55, something seems to happen. If you've got COVID and you're feeling bad enough to come into the hospital, that seems to be the age where it tips that you're likely going to be admitted. And what we see is from about age 50 to 75, that number is about a 75% chance that we're going to admit you to the hospital, all things considered. So, and it's gratifying to see a number of younger people who come in who have COVID, recently got tested, or we find they've got COVID while they're here. And their oxygen level's good. We walk them and do a little exercise tolerance test. The oxygen level doesn't drop. All other things being equal, we're like, wow, we can manage you at home and continue to follow, do your self-isolation and go from there. And many of those patients, the majority actually do quite well in those age groups. And again, like I said, it's just we use our clinical experience to say, what is the likelihood that you're going to get worse, and really try and apply that to people. But that's our experience based on the numbers. And then one last slide we've been putting together is looking just at ethnicity, and just with a lot of the concerns about disparity that occurs in healthcare, just looking at our the baseline racial makeup of our population compared to the COVID positivity rate. And it looks like there's a decent amount of equality, as at least, or equity seemingly, to the numbers of people infected versus their percentage of the population that comes to the ED. So that's kind of interesting. It doesn't account for everybody in every circumstance, but it's just at least a peering into our experience with different populations based on ethnicity. Let's see, what else did I have? Yeah, that's basically been it. I mean, I think that, we continue to be hopeful in terms of our day-to-day work. We're grateful for the different therapies that have come out. I got my vaccine last week, so I'm hopeful that it'll continue to do the things that have been forecast, and I'm very hopeful about that. But I think, as Dr. Wild said, we're definitely not out of the woods. I hate to think about, so to speak, the March 2021, which will be my 1-year anniversary of saying, hey, this is really a big problem here. That we could be a little bit even deeper into this this pandemic and the toll that it's taking. So
Yeah, I'm afraid about the toll. I'm hopeful that with vaccination and warming weather, that people getting back outside and hoping the vaccines hold against the variants, that we'll see a little less pressure on us. That would be a really good thing.
Yeah.
But in the meantime, it is still a slog, isn't it? And I think your data shows great. Well, I just knew you were super smart back when you were my intern, and you continue to impress me, David Lisbon. That was outstanding. Thank you. So what do you think needs to be done for vaccines? If vaccines are our next great hope, how do we make sure we get them to everybody? Because I think as an ED doc, you and I both know the vaccines are what's going to help take some of this pressure away from the ED.
Yeah. Well, I mean, the ID doc is here, but from my perspective, I think, we're living in an age of unprecedented access to information. Not all that information is good, but people can query a lot of this information for themselves. There's a lot of skepticism of broad communities about vaccines based on all kinds of things. And I think that it's already happening, us as physicians having, genuine organic conversations with the people we run into or are part of about why we believe it's a good thing will be helpful. I think organized forums to discuss this for communities of color who have been perhaps marginalized and mistreated by a medical system in the past, that's going to need to be done too. And I think that's going to need to be done out front as an admission of the shortcomings of the system in the past, and then to talk honestly about what kind of benefits we believe that vaccines have brought, continue to bring, and are particularly likely to bring to this particular pandemic. So yeah, I think, I run into people who are all for it. I run into people who continue to be somewhat skeptical about why they should take it. Sometimes that's something that's just a suspicion about what medicine is doing, and sometimes it's just a wariness of saying, well, I'm okay, I'm a low-risk person, do I really need to do that? And then there is, to me, what I see a large part of the naturopathic leaning community that just wonders, should you be putting extra things in my body, etc. But I'm a big advocate of, I'm not old enough to remember polio per se, but studied it and the effects that vaccine was able to have in terms of eliminating that, smallpox, all kinds of things that we've been able to triumph over. So, but of course I'm biased as a scientist and a doctor, and I freely admit that to people, but and I respect their right to be skeptical. I just think that they need information, they need honesty, and then they need to weigh these factors and decide.
Science is great. You and I, we're all three, all of us very biased about it. Respect is earned, right? The ability, as you pointed out, the ability to voice an opinion is free. As you sit back and you look at the entire expanse of this pandemic, I think we have to ask ourselves, who has earned our respect by telling us things that have turned out to be right and truthful, and has always been pretty honest about it. And I think as you listen to the voices that are outside in this pandemic, there are a lot of them. Some of them flapjack, you've heard us say that before. Some of them are pretty honest and straightforward with us. And I think there are those who have tried to tell us what was going to happen. And sometimes they were right, but again, when you're building an airplane while you fly it, sometimes it's wrong. But they've always been honest about it. That guy right there, that guy has been the one who has earned our respect. That's the voice we need to listen to, because he keeps trying to tell us the truth. And if you look back at the great body of his work, he's the guy that's been right so many times. Not people who don't have a founding or grounding in pandemics, or people who don't have a founding in science and kind of make it up. You got to listen to the guys who really know what they're talking about. I know someone who also usually knows what they're actually always knows what they're talking about, and that's Dr. Catherine Satterwhite. Catherine, welcome back. Tell us about what's going on from an HHS perspective and what you see is happening with vaccine distribution. When will vaccines be getting into the arms of folks and patients outside of healthcare?
Yeah, sure. Good morning.
Good morning.
And I think I'm glad you asked me that, because I think that Dr. Wild and Dr. Lisbon both shared some amazing data that really talks about what I call the disease burden. So, how many people are getting sick, what's happening to them when they get sick. But we have a vaccine, and I think it's really exciting. And I know that you've probably seen there's been some bumps as the vaccine has rolled out. And like I think Dr. Stites, you have said, a lot of us in the scientific and medical and public health community anticipated those bumps, but it's still difficult to deal with when you know it's out there, but you can't get it. So states, Kansas and Missouri and Iowa and all the states in the area have been working really hard these last couple weeks to help improve what we call throughput. So how many people can get a vaccine on a given day and a given hour, to try to make sure that we're getting as much vaccine out as possible. You guys probably knew that, when the data were initially released, it looked like we had all these doses sitting there. So there's two things about that. One, there's the data lag. We know that some of those vaccines have actually been administered, and our systems just need to catch up. There are many, many pieces that need to be in place to have a smooth data flow. I won't go into that. There's lots of smart people working on that. The other thing we know is we had to work through these bumps, and we're seeing some really great examples now of places that are optimizing a system to keep people moving. Wyandotte County and Johnson County both have community-based clinics where they're really able to vaccinate those phase 1A, those healthcare workers who maybe aren't part of a hospital, so they don't have access like a KU physician would. So they're able to go to these community-based clinics and get their vaccine there. And, again, we're taking care of these people that we have prioritized to help really build that foundation to the community as we move forward. So, and I just want to say one other thing. While it's amazing to have this COVID vaccine, and we will continue to roll it out, everybody's working on really ramping up for that next phase after healthcare workers. We also know that people in our nursing homes are getting vaccinated. CVS and Walgreens are setting up clinics. They're going to nursing homes to vaccinate all of their staff, all of their residents, and they're going to come 3 times to each nursing home to make sure that they get the coverage that they need. But my last little thing that I want to say about vaccines is, and we heard this, I think, mentioned by Dr. Lisbon, it is winter. If you haven't gotten your flu vaccine, that is something that you can do, and it does make a difference. So go out and get it if you haven't gotten it. I know that Dr. Stites, you guys have talked about it a lot on the show, but just a reminder.
Yeah, you bet. I think that is critically important. So, Hawkeye, you've heard a lot of important information here this morning. Thoughts that you have about it as you kind of look perspective to the 200 days?
I mean, there's been a lot of thoughts. Just such great information from David Lisbon, David Wild, Catherine. You know, I think the biggest thing is the chart that you showed, David. And it isn't just one wave or two wave. That was early, but I think it's now just more this amalgamation of just this huge blue wave of everything going on at once.
Yeah, at once.
But I think importantly to your point, it does matter what region. And I think we have actually been fairly lucky here in the Kansas City region compared to some of our neighbors on the coast, or in Chicago, say, or down in Louisiana. But all of those things were going on. And the lack of resources, initially we thought it was PPE, and then it was critical drugs that you need when you're on the ventilator. We know that you need those. Those were important. But then it's also the lack of resources for other things. And we've seen, and we've had people on talking about this, for people who have stroke and heart attack who can't get to the hospital or can't go to their local hospital because their local hospital resources are taken up. So I think that's the most important point. And we are in all those. And then in that fourth wave as well, we've been talking about the mental and the psychological trauma that we are talking about. And that's the brain fog, but it's also people who haven't even had COVID. And it's the traumatic issues there in their mental health because of lack of work or, like you said, getting displaced, things of all that nature. We are in all of those waves, and they are concurrently going on all at the same time at this point.
Agreed. Yeah.
All right. Well, Jill, this has been a great opening, but we haven't had much time for questions. So let's turn and just see if we can get a few questions in today.
We do. We have questions, but before we do that, I want you to look to your left, and there's a little gift bag sitting there. Our team wanted to.
That's left. There we go. I couldn't figure out which side it was.
And it's tiny, and inside, if you'll reach in it, there is a gift for Dr. Stites and for you, Dr. Hawkinson, from our team.
All right.
We wanted to recognize this milestone. You have
Look
taught
at that.
us.
Thanks, science. I love that. That is so cool.
You've taught us how to keep safe. You've taught us about COVID, and our next lesson is about vaccines. And so our team wanted to say thank you.
Well, you are very welcome. I want to
you.
say thank you to you guys. Okay, so first saying thank you. I had my thank yous written out, but now you've forced me to go there right now. A couple of quick thank yous, and then we're going to go back to some questions. First, I want to say thank you to our entire team of interpreters. Chris, thank you. Michelle, Christine, this whole group of people, they've been great. They've been with us almost since the very beginning and do a great job making sure we get this message out to a lot of different folks. Jill, you worked awfully hard at this. Jill said to me yesterday, this has been the most satisfying and important thing I've ever done in my career and in the history. You've done a lot. And I think certainly it's one of the biggest things I've ever done. And nothing I ever thought what I would ever do. So I want to thank you for making us feel comfortable. But thank you for keeping us on task and on message. And you've done a great job.
She's the motor.
She's what?
She's the motor.
She is the motor. I mean, oh my gosh, she organizes everything. And thank goodness you're here in this moment. And you've had this preparation so we can help get this message out to everybody. Well done.
I appreciate it, but
And to Logan.
Yeah.
I'm going to get there. Did you think I would forget Logan and Anthony?
without the team.
Well, so let's take a shot. Hey, guys. So Logan and Anthony are really the brains and the brawn of this organization. And I'm not saying which one of you is brawn. I'm just. But these guys are really the ones that keep us working all the time. Anthony joined us as an intern, I think, and he now works here at the health system. We grabbed him. He's done a great job for us, and we love having him aboard. Anthony is also a survivor of COVID-19. Logan, who has been here with us the whole time, is kind of that rock steady guy, doesn't get flustered, just keeps things on time, make sure we're working, make sure I got some ideas in my head, and I don't say too many stupid things out here every day. So these guys, this whole team is remarkable. So thank you. Thanks to everybody out here. And this pen is going to go on my jacket as soon as I get somebody else answering a question.
All right, we're going to get the first question to Anil. He's one of our long haulers. He wants to know if we track the percentage of people admitted who need ventilators.
We do. David Wild, do you have that off the top? Because you're the guy with the man with the plan about the data. So.
Yeah, we do, and it's 400 and some odd, maybe 500. I haven't looked this week, Anil, of the total admissions. So you can sort of get that sense. Figure it's 500 out of 2,000 is roughly the percentage.
So that's a pretty good percentage, right? If you had 500 out of 2,000, you're talking 25% of our patients need to be put onto a ventilator, and that's not a statistic any of us would love. And as a pulmonary critical care doc, I'll just tell you, and I don't do the ICU anymore, but I look at my colleagues, my friends who are there, and I think it's traumatized a lot of them. And we said this yesterday. You know, the other person who is traumatized a lot is our nursing staff. Because you think, as physicians, we kind of move in and move out, but the nurses are there on an ongoing fashion. So when these young people die, and again, our relative age is 67, that's still pretty young to be dying. Remember, the average age of survival in the U.S. is 74 or whatever. So there's a lot of young people who have died. It's our nursing teams that have had to bear the brunt of that and are there with a lot more death than they are accustomed to. And these are young people watching folks die in unprecedented numbers. And they often are the ones who have to work with families, and oftentimes families can't come into the hospital now. There's one, so someone has to be there emotionally for these people who are dying, and then they have to help put them into body bags. And that's the job that our nursing staff does every day, and does it with a degree of excellence that is remarkable. I also saw another data point yesterday. Our patient satisfaction here is the highest that it's been. What does that say about our team? Because if you can have a high patient satisfaction in the midst of a pandemic when families can't even hardly be in the hospital, that is a staff that is going so far above the normal call of duty. So I think a lot of thank you to our whole team. And I try not to be real biased about KU. We try to talk about everybody here because we're all in this pandemic together. But a special shout out to our nursing staff and our respiratory therapists and our frontline staff, as well as our docs and every providers who are out there providing that care that makes people feel that they're getting the best care, even as they're dealing with this terrible disease.
Several people want to know if Dr. Satterwhite has any crystal ball into when 65 and older and people that are not in nursing homes but are elderly will be able to get the vaccine.
You bet. Yeah. And so, and Catherine, as I'm going to ask you this, I'm going to set you up with something, because yesterday it was reported that Walgreens and CVS are going to start vaccinating people in the community soon along CDC guidelines, beginning with those over 74, or I think it was 70 or 74. So thoughts about that and the question that Jill asked?
Yeah, first of all, it's a really good question, and something I think a lot of people do want to know. So ACIP, the Advisory Committee on Immunization Practices, recommended 75 and up as the next tier. So it's phase 1B after what I was talking about a little bit earlier. I don't have a crystal ball. However, there are some states that have already moved into that. Alaska is an example. So some of them just have different a variety of different factors that go into that. Locally, we do know that our states are doing a really good job of getting through that first phase. I'll throw out a guess. I think maybe a month, but I do want to just make sure that everybody understands. While I said that 75 and up is the national guideline, states are making independent decisions about what that lower age cutoff will be. I've definitely seen states talking about 65 and up. I've seen states talking about 70 and up. So I think what you have to consider is the state guidelines are what's going to drive local access. And yes, the pharmacies will play an important role. That's been a system that the federal government has really tried to leverage. A lot of people in the whole country are within 5 miles of a pharmacy. So those are going to be a really important distribution point. And CVS and Walgreens are well set up to launch that program once the guidelines, once they get the go button. I hope that helps. I know it's not a magic answer.
I think it does. But David Wild, you and I know that the VA has started doing some work here. Dr. Ahmad Batrash, who's one of the chief of staff there, was on a call with us and talking a little bit about the VA's approach. Do you want to talk a little bit about that?
Yeah, I think it's a really interesting and important point that the VA system has, outside of a state distribution plan, right? They're not provided doses by KDHE, for example. If you're talking about the Leavenworth VA in Kansas, it comes from the federal government directly. They've begun, at least at the Kansas City, Missouri, the KC Missouri VA, they've begun to administer vaccine to veterans, not just healthcare workers in their system, but to veterans who are patients in their system, of course, by some age guidelines and with prioritization. And I think that is a good sign that we will have ways and plans, as Dr. Satterwhite mentioned, systems that are well positioned to do these things. And And of course, it's great to hear that the VA already is, because that means that we're starting down that road.
And Catherine, I saw you shaking your head yes, so you may know something. Anything else you wanted to add to that?
Yeah, just briefly, I'm so glad you mentioned that. The other there are a couple special groups that I think are worth mentioning who are going to be approaching this a little differently. One is the VA. One is the Department of Defense. So you may have seen pictures sometimes of our active military getting vaccinated. The Department of Defense has that purview. I know I saw some Fort Leavenworth soldiers getting vaccinated, which I think is really important for our community to see too. And then the other group I want to mention is the Indian Health Service. And we do have some tribes in the area. And so they also have sort of a separate distribution system going on.
You can certainly understand each of those, and gosh, we got to get the military vaccinated. That just feels like absolutely the right thing to do. So I understand that Taylor on Channel 41, who I think has been with us for 200 episodes, Taylor. So welcome back.
He's been here for
you
201.
and Cody. You and Cody are the two folks I can count on. So Taylor, I hear you have a question, please.
My official count is 191, so I'm not full
Yes.
200. Yeah.
We're going to celebrate when we hit
not that
201.
Not that I'm keeping a tally or anything like that. I want to ask you about school safety and preparedness, because we're getting more schools that are set to open at different levels now that we're in the second semester, some welcoming back their older students, that kind of thing, to at least hybrid learning, some even more than that. Can you give us an updated look at, for lack of a better phrase, bang for a buck when it comes to cleaning large spaces like that where groups are going to be in? I know we've talked about the importance versus the need for wiping down surfaces and that kind of thing. But since some of these buildings are going to have students back in them for the first time in months, where are schools getting the most bang for their buck when it comes to cleaning those areas?
All right, Taylor, I'm going to throw you a curveball for this. You ready? So, and Hawkeye can correct me. So, in the world of COVID, it's become pretty clear, I think, that spread through the air is a much more important aspect of this disease than spreading on surfaces. However, we're in the midst of the winter, and it's important to keep us healthy on every aspect. So surface spread of things like rhinovirus or enterovirus is still very common. So as a result, wiping down surfaces can help keep kids healthy in all aspects, which is important because otherwise, I think when kids get sick, their parents get sick, and then everybody worries about COVID, and then we cause even more stress to our healthcare system. So I would say to you that for differing reasons, it is still very important to wipe down surfaces. But in terms of just COVID alone, I would say nothing is going to replace masking and distancing as being important. But when you think about healthcare overall, Hawk, I think we got to do all of the above.
Yeah, and I think for those schools, we've always advocated for just routine environmental cleaning, using those routine cleaners, not real special cleaners. There is, most of those cleaners have EPA numbers, or you can go to the EPA and look up the specific number to see if it has activity and if it's approved or whatnot. But really, most typical environmental cleaners that you find in industrial places or schools or the homes will be enough to clean the surfaces. And I think just continuing to do that routine surface cleaning is going to be important.
All right.
I'm going to give the last question to Sean.
Okay, Sean.
It's a good question. He says, if you are asymptomatic for COVID and you don't know it, what benefit does being vaccinated give?
Oh, that is a great question. But on the other hand, remember that we have two things. We're both on offense and defense, right? That's why we wear a mask, because we can get the benefit from masking, because we can be asymptomatic when we spread, so we don't spread it for others. And two, if you get vaccinated, the likelihood is, even if you get an asymptomatic infection, you're not going to get as sick. I mean, the data, Hawkeye, from both Moderna and Pfizer is overwhelming around the acuity of illness. Even if you get sick, you just don't get anywhere near as sick.
Yeah, absolutely. I think there is that benefit. Is there some signal, or is there any evidence that you don't spread it as much or don't replicate the virus as much after the vaccine? That is still being studied. There was maybe a little bit of signal in some of that Moderna early data, but it is important to continue to do the masking and the distancing. But I think the important thing is, as Dr. Wild had showed, there are averages, but there are people on the ends of those averages, older ages and young ages, and really anybody is at risk of getting disease that needs hospitalization or even severe disease. Now, the risk is less if you're younger, of course, but it certainly increases with other comorbidities, including age, but also diabetes, weight, obesity, things of that nature. So, that will protect you from the risk of getting, just as Dr. Steit said, disease and especially severe disease.
All right. Well, let's circle back to each of our guests as we look back over 200 days and hopefully not going forward 200 more days with this, but could be. Catherine, final thoughts?
I just want to thank everybody for all the work that they've done. Dr. Seitz, you mentioned really thanking nurses and respiratory therapists and all of our healthcare workers, but I want to thank the community members who have continued to make hard decisions, uncomfortable decisions sometimes, who have stayed away from family when that's what you want and need. So keep making the hard decisions, and hopefully we'll get to a place where you can do those things that you so miss again soon.
Dr. David Wild.
Yeah, I'll tag on to that just a little bit. We've talked a lot about how every member of our community, everyone watching this update today, has a role and a responsibility in keeping our community, the population at large, safe. And up until now, that has included all of the pillars of infection prevention and all of the things that Catherine just mentioned, right? Even when you don't want to do them, avoiding time with your family, for example, at the holidays. And now, as we enter this phase where more and more of the general population will be eligible for vaccination, the responsibility for each of us begins to grow because now we have a responsibility to make sure that our population, our community is being vaccinated. And while some of that is individual for us or even for our family, I think we've hit on today already that the facts, the information, the truth about these vaccines, what we know and what we don't know, remains an important part of vaccine acceptance. And it's important to realize that we'll all have a role to play in going forward, not just for the pillars of infection prevention, but now also for vaccine uptake.
Thank you. Thanks to you both. Dr. Lisbon.
I think I like to just thank the community. I interact with a broad swath of the public in emergency medicine, and I enjoy it, love it, and I have appreciated the well wishes and the appreciation for the hard work that our nursing staff, our techs, our residents, and myself as faculty are doing to address your needs and ensure your health. Like Dr. Wild said, going forward, careful consideration about this vaccine, and I'm sure the health system will be doing things to get more information that's informed for all of our population will be important. So I would like to say, I think, folks, as I said before, continue to have faith that science will help triumph and just continue holding on and being diligent about the things that we know that do work.
Thank you. And thanks for being back on our program again.
Oh, yeah.
Doc Hawk?
Yeah, it's 200. Hopefully we don't have to do 200 more, just as you said. We would really like it for it to go away. Keep everybody, your loved ones, your family safe. Keep doing those things that we're talking about. It has been a long road. It will probably continue to be a long road. We will try to continue to give you the most up-to-date and accurate scientific and medical information and answer all your questions. But the biggest thing you can do to keep yourself and your loved ones safe is continue to mask, distance, not meet in large groups. We are hoping that, as the vaccines roll out, just as you said, as it gets warmer and people are able to go outdoors and do those things responsibly, or just as we saw in the spring with, physically distance out in the neighborhood if you're meeting together. That's going to be important, but we still have a long way to go. So continue to do those things. Please ask your questions. We will try to answer them to the best of our ability and give you the correct information.
It has been a long road, and it will continue to be a long road, but we'll be here with you. Hey, tomorrow, I won't be here. I'll be doing some doctor work tomorrow and on Monday. I'll be back with you on Tuesday when Lee Norman returns to be part of our program. We can talk more about the vaccination strategy here in the state of Kansas. David Weil will be helping host, along with, of course, Doc Hawk, and Amanda Gardner, our Director of Quality and Safety here at the health system, will be here to be taking community questions. Wow. Oh, a couple other points. There's also an important graphic for you to see. Some of you may be interested in a Facebook and YouTube town hall discussion tonight, sponsored by blackdoctor.org. It starts at 6 p.m., goes to 7:30 p.m. Central Time, and is called Making It Plain: What Black America Needs to Know About COVID-19 and Vaccine. I think that'll be an important event. I'm going to try and tune into that. So I think that'll be a really good thing.
Panel, I would say there's an excellent panel of individuals. I know some of them personally, and they will give some very, very good information.
Yeah, it's great. And Fauci's on it. And Dr. Valerie Montgomery-Rice, who used to be faculty here at KU.
And
so.
Vivek Murthy he was here and spoke when Lee Norman was CMO. So yes, it's a very distinguished panel, but also one that I think will be honest about the challenges that we face.
Honesty is important. You know, man, I don't know how we can recognize the events that happened in the Capitol building yesterday. That was certainly a troubling time. And against the backdrop of this pandemic, it feels like what we really have to be is honest, right? The road to recovery from the coronavirus is not driven by falsehoods or lies. The only way to get there, and we've had this somber tone today, but it's true. The only way to get there is to really have a meaningful, honest, and truthful discussion. That's the way we can beat the coronavirus. And what it means is you have to be on offense, you have to be on defense. We know what defense is, right? I've got a couple of cool masks just to say. My sister sent me these for Christmas. The first, to mask or not to mask, is it really a question? And keep your distance, because gosh, we can't end the program without a Star Trek reference. Boldly go 6 feet away. So indeed, you know what? We've got the answers right here, and then you've got to get vaccinated. I think in one of the speeches yesterday, someone quoted Abraham Lincoln. Here's what Lincoln said. "We shall nobly save or merely lose the last best hope on earth. The way is plain, peaceful, generous, and just. A way which if followed, the world will forever applaud and God must forever bless." Now, he wasn't talking about COVID, but he could have been. Think about that. The conversation should be plain, peaceful, generous, just. That's what this program is for 200 days. That's what it's going to be for as long as we need to be here to help us all work through this crisis together. This is a partnership. Our team, Jill, Logan, Anthony, Chris, all the folks you see in this room, we are here to work with you. And Jessica Lavelle. Yes. All of us are here, and it is a partnership with you. We'll continue to not flapjack and tell you the truth. We'll continue to wear masks. We'll continue to distance, and we'll tell you what's up with the vaccine. Thank you for being a part of our journey. We're here with you. We'll be back tomorrow.
Just how long should people expect to kind of be living this way?
That is a day-by-day thing. That is looking at the data, looking at the cases.
I think it totally depends on what our response is. If it's an inadequate response, it's going to go on for a very long time. Things are changing rapidly, and we're beginning to see an increase and an uptick in the number of positive patients here in Kansas City.
Our unit has switched over to taking COVID positive patients. That was a shift just in 24 hours.
We really do need to try and stop the spread as much as possible. Today, we are at 26 inpatients. We have 8 in the ICU. Today, we have 20. I think we had 20 or 21 yesterday. We are back down to 10. Today, we have 33 in the hospital. Today is 23 in the hospital. We have 24 inpatients in our hospital. We had 15 yesterday. Right now, we have 36 in the hospital that are active infection. We have 80 total acute infections right now. 101 acute infections in the hospital.
I say it this way, the economy can't recover until people feel secure in their health.
The classrooms this fall and winter are not going to look like what they were in the springtime.
We didn't have the PPE necessary. We had blood shortages. We had medication shortages. We're in a different place now, but now it's come down to beds.
We don't know when COVID will end. That unknowingness can be very difficult for us.
My husband passed away from it on May 11. He worked at Lansing Correctional Facility where there was a big outbreak.
Be mindful that this is a disease that can kill some people.
I think it's been harder on my wife than it's been on me. My wife wouldn't sleep at night because she was afraid I would stop breathing.
Stay at home, love each other and your family.
This is a liquid handler.
We're on the plane now.
This vaccine is one of the most remarkable achievements in healthcare in the history of human civilization. And I'm not trying to be dramatic about it. That's just true.
All right, stick and burn here. 1, 2, 3.
There it goes. Good. Vaccine in.
Ready?
Yes, ma'am. I'm ready. Let's do it.
Thank you all for all the work you've been doing to keep local communities informed about the pandemic. Please keep spreading the word.
We're just going to tell you the science and the truth as we know it today. Here's what we know. The rules of infection control go with you everywhere you are, and if you'll use those pillars, they help keep you safe.
We do put a lot of time in, put a lot of effort toward getting everybody the correct information, and that does come from, respected medical journals for our sources of truth.
Doesn't mean we have all the answers at all, but we'll always be honest with you. Remember, stay safe, and still, there's no place like home.